Hello Insta family, how are you this evening? Hope everything is going well. It is Wednesday night and it is super hot here. We are having a lovely heat wave here in Perth, and so it is great for the hot flushes. Now, we are on here for Q&A live tonight. Lovely to have you on. Danielle Dolphin by Elizabeth Jane. Who else is on? Rach, Perry Pilates, Melly Moo, Mirella, Rach, Georgie, Michelle. Good to have you guys on. Yes, I am feeling fantastic. Thank you so much for asking. So we're going to launch right into things, Q&A. It's lovely to be back and into it in 2024. So just a little guideline how we run our Q&A sessions. Please don't hesitate to drop your questions into the comments section. Try to keep them as succinct as possible. Don't really want to hear your life story because I'm going to try and make the answers as succinct as I can and general to the population. I can guarantee you that the questions that you ask, there'll be others on here who will benefit from the answers as well. So that's why we want to keep it as generic as possible. Anything that you don't get answered tonight, you can always send me as a DM and I will aim to answer it the following week. So 2024, what questions does it bring? We have our first one here. Is McLaughlin, if I have a very low AMH, do I need to start treatment right away or are there options to hold off? Okay, so the first thing to keep in mind that a low AMH is not a reflection of fertility. It's just telling me how long your reproductive potential is. So it doesn't mean that you're infertile. It really depends on your particular situation. If you're single and you're some years away from having a family, if you're wanting a big family, it may be that you would like to consider egg freezing. If you have a partner and haven't tried to conceive, maybe you only want one child, then it's really reasonable just to try to conceive now. So there's actually lots of, I suppose, solutions depending on your individual situation. The one thing that I will say about AMH, yes, it is very well correlated with your ovarian reserve, but there are some things that will suppress it, namely the combined oral contraceptive pill. So if you've had your AMH assessed on the combined pill, then you will need to have stopped it for at least 3 months and have that AMH repeated. And I would always suggest getting an antral follicle count via ultrasound as well. So same-sex couple, so added considerations. Again, you know, the added considerations about sperm donation. I know in Western Australia there is probably about an 18-month wait list, so you've got to take that into consideration for donor sperm. Even if you were using a known donor, you've probably got about 6 months. So it might be that you consider egg freezing. Absolutely, you need to talk to a fertility specialist about your specific situation and make a informed decision about what you want to do. Good question. Danielle, any tips or tricks for frozen embryo transfer? Don't think that there's any tricks, but there are certainly some guidelines that are suggested. Whether you use hormone replacement, FET, whether you do natural cycle, low dose stimulation, the results for pregnancy success rates are very, very similar. So you could consider all of those. We do know that having the presence of a corpus luteum, so in a natural cycle or a low dose stimulated, what we call modified natural cycle, it is better to have the corpus luteum around for late pregnancy effects. And certainly in our clinic, we think that a low dose stimulation cycle probably yields better pregnancy success rates. Where was I going with this? Okay, so have a chat to your specialist about the right type of protocol. On the day, I would definitely recommend having a decent bladder. If you have an anteverted uterus, so it faces forward, making it axial will be really ideal so that we've got a nice smooth pathway to pass the embryo transfer catheter into. We always suggest that you do it under ultrasound guidance. That tends to get the best success rates for pregnancy rates. There is some relatively new evidence to suggest that transfer in embryo glue might actually improve outcomes. Embryo glue is hyaluronic acid, so I certainly recommend to my patients to have a transfer with embryo glue. Yeah, so there's some of the tips, I guess. I don't think there's any real tricks other than making sure that the person doing it has done a few, because it is certainly associated with competency. So the more competent your practitioner is, the better your success rates are going to be. So hopefully that is helpful for you as well. Look forward to meeting you, Is McLaughlin, or seeing you again. Rach Perry Pilates, hello, my friend. Will the eggs in extra large follicles be over mature and unusable? No, not over mature. I don't think we have over mature. It's either an M2, which is a fertilizable egg, or an M1, which is a non-fertilizable egg, which might actually mature after pickup. So we always give them a chance. But extra large follicles, no, generally speaking, if you've got, if you're challenged by large follicles, we give you orgalutran, a GnRH analog, to try and suppress that LH surge to make sure that you don't ovulate those eggs off before your egg collection. But no, not unusable rate. Okay, Danny Vandenbach, any tips for the 2-week wait in terms of food, exercise? Look, Danny, I know that the 2-week wait is incredibly stressful. I actually think in the whole process, it is the most challenging time, because you put all this work in with blood tests and ultrasounds and treatment and that uncertainty about, will my embryo thaw, or will I grow enough embryos out to day 5? And then all of a sudden you've kind of got to sit on your hands for the next 2 weeks and wait for the result. Live your life in moderation is my best piece of advice. So of course you need to be on folic acid. I wouldn't be drinking. I wouldn't be smoking. I'd be minimizing the amount of caffeine. I would be doing mindfulness activities. I'd be getting enough sleep, all the things that you would do that would suggest a healthy lifestyle. That 2-week wait is not the time to start juice fasting or Bikram yoga classes in heat. It's not a time to be doing new things, but it is certainly a time to be looking after both your physical and your mental health. Alrighty, any other questions? Oh, there's more questions coming through. Cat M Black. Hey, Dr. T, is there much benefit in delaying surgery for endometriosis? Depends what your outcome is. If your outcome is to overcome symptoms, pain, for example, no, there's no real reason to delay. If you are wanting to improve fertility outcomes and you have known endometriosis, no, not necessarily. So it's a bit of a vague question. I'm struggling to know what your outcome measure is, so maybe try and clarify there, but I don't really see a benefit to delaying surgery for endometriosis, unless you're talking about diagnosis. If you're a young person and you are presenting with very vague symptoms, particularly pelvic pain with a normal ultrasound, it would be reasonable to try conservative methods to start with. But if your symptoms are persisting and you don't know what's causing them, then it's really reasonable to have a diagnostic laparoscopy performed by somebody who is skilled at the treatment of endometriosis. You kind of want to do it once, do it well, but then you also need to be open to some sort of management. So if you're not wanting to conceive, then suppression of any further development of endometriosis, and that often requires hormones. Or if you are found to have severe endo and you have infertility, then your consultant may be recommending moving on to IVF. So you have to be open to what the outcome will be once the diagnosis has been made and the treatment has been instituted. So I don't really see much of a point in delaying, but it really depends on your clinical situation. All right, any other questions? There must be other questions coming. Lots of people have joined us. Celiac dietitian Jess, hello. NutriSmart supplements, hello. Jenny McCavendish, Jazzy Keo, Hi guys, welcome to the live. Does anyone have any questions that they wish? Just drop them into the comments section. Try and make them as generic as you can. Anything else that would like to be asked? I'm just flicking back to see if I have missed anything at the start. Hello, Michelle Arnold. Lovely to see you on. Any other questions? Everyone's just waiting with bated breath. Scott Older. My partner had mild inflammation in her remaining tube after a post-op infection to have a large cyst removed on one of her ovary. She has 2 miscarriages, both blighted ovums. Yep, what's your question? Oh, here we go. Could the inflammation be causing those miscarriages? Absolutely, absolutely. So we know that inflammation in the tubes can produce inflammatory fluid, which can be refluxed back into the uterus. And generally speaking, we would encourage removal of a tube that may be inflamed or have presence of a hydrosalpinx. So yes, so if there's a damaged tube, it's kind of unusable anyway. Just because a tube is open doesn't mean that it is healthy. They've done studies to show that if you actually remove a fallopian tube, flip it over and reattach it, even though it's patent, like a hose pipe, it won't actually work. So it is absolutely worth considering a good quality ultrasound to assess for presence of hydrosalpinx and then removal of that tube to improve pregnancy rates and reduce recurrent miscarriage. So yeah. Righty ho. Georgie Morris, when is IUI suitable rather than going straight to IVF? There's not very many clinics that suggest IUI anymore, just simply because of the really poor pregnancy rates. So at best, you're probably going to have a pregnancy rate from an IUI of about 15% per try. So the background rate of fecundity is about 20%. As we get a bit older, our fecundity rates drop, or our fertility rates each month drop. And IUI probably maximises, maybe doubles your background chance of conceiving. So if your background chance is about 5%, you might get a 10% chance of falling pregnant with an IUI. So for all the effort that you put in, it's actually not really a very successful treatment. You also only have one egg released and the opportunity to be fertilised. Yes, the sperm is closer, but what if it is that the egg that you actually release to be fertilised is chromosomally abnormal? You won't know that. You might not pregnant, or you might not get pregnant, or you might have a miscarriage. So there's lots of reasons. I think that a young couple, perhaps in their early 30s, with unexplained infertility, who might have only been trying for 12 months, it would be reasonable to consider IUI. I would certainly not languish there for more than a couple of cycles, because you tend to find plateauing pregnancy rates with time because there's something else going on. So there are certain patient demographics where we would consider it, but you'll find many fertility specialists don't even offer it anymore. Okay, Yana Catania, chances of IVF pregnancy after endo? There's always a chance of an IVF pregnancy after endometriosis. Is this endometriosis surgery? Is this what stage of endometriosis? It depends on how good the surgery was to remove it. Like, there's lots of factors. We certainly know that pregnancy from an embryo transfer in a woman with endometriosis versus, say, a woman who has blocked tubes is lower. Pregnancy rates are lower. So we do know that women with endometriosis struggle a little bit more with endometrial receptivity. But certainly there is always a chance in the context of endometriosis. Liz Kuto, what would you do for recurrent implantation failure? Liz, a lot. Firstly, we need to decide if this truly is a diagnosis of recurrent implantation failure. How good were the quality of the embryos? Were they euploid embryos, i.e. normal chromosomes? You need a good quality pelvic ultrasound. You need a workup for thrombophilia. You need endocrinology screening. Your partner probably needs DNA fragmentation of sperm. There is a lot to be done. And so personally, I would be going back to the drawing board to see, is it an embryo issue or is it an endometrial receptivity issue? Maddie Post, do we have an age limit in Australia for ART implantation with donor embryos or using donor sperm and eggs? Every clinic has its own age threshold cutoff. So I would suggest that you speak with your clinic who offers egg donation or sperm donation, because it is very, very clinic dependent. I will say that it's somewhere around 50. So as I said, every clinic is different, but it's somewhere around that age group. Yana Catania, also, at what age situation do you implant multiple embryos? Is there a policy rule? There's no real policy or rule. I think, again, that's a discussion piece. Certainly, we know that double embryo transfer will increase your implantation rate and pregnancy rate. However, it also increases your multiple pregnancy rate, which is not our desire, and it also increases your miscarriage rate as well. So you've really got to weigh up the pros and cons. I would talk to your fertility specialist about it, but there's no specific rule. In Australia, we do prefer single embryo transfer, however. Whew! How was that, guys? It's now 7:50, so we've been at this for about 20 minutes. I think we'll call it a night for tonight. Thank you for those questions. They were fabulous. If you do have any further questions, please don't hesitate to DM me, drop it into my DM, and I will certainly put it on the list to answer for next week. It's so great to be back. It's great to be doing Q&A live. I hope you do stay with me for 50 days of Dr. T. I've got some fascinating information to share with you over the next few months, I guess, as well as my journey back to me. Oh, I'm glad that you loved the webinar last night. Yes, I did a webinar with Dr. Tony and Dr. Thea, also Monash IVF clinicians from over East. It was lots of fun. So keep an eye out for those webinars as well. Have a beautiful rest of your week, everybody. Stay safe, look after each other and yourselves. See you later.